Welcome to Module 3, What You Need to Know in the Exam Room. In this module, we will learn how to apply material covered in Modules 1 and 2 when interacting with patients. First, we will become familiar with the current American Medical Association public health policy regarding firearms. Next, we will describe the role physicians can play in discussing firearms with our patients. And finally, we will identify each patient by category, standard, increasing, or high risk for firearm injury, and learn about the different approaches for each category. As physicians, we are often faced with making decisions about how much to ask in an exam room gray area. We must weigh what questions might be seen as an invasion of privacy and harm the patient-physician relationship, versus what questions might elicit life-saving information. Is it our role to assess firearm risk in the first place? The current American Medical Association policy directly recognizes firearms as a serious public health threat and supports free and open communication with patients about firearm safety, including inquiring about the presence of a firearm in the home. According to the AMA, it is exactly our role and our place to start the conversation with our patients and address gun violence for what it is, a public health issue. Firearms impact all specialties and all professions. Multiple studies have found that between 75 and 82% of parents would find information on the safe storage of firearms provided by a pediatrician to be helpful to them. In a study among older adults, 62% felt comfortable with their physician's screening for firearms access. So, across different patient populations, from pediatrics to geriatrics, the majority of surveyed groups agree that screening and counseling for firearms access and storage is warranted in the exam room. The May 2018 American Medical Association Journal of Ethics highlighted the complexity and intersectionality of violence in general. Risk factors for violence include repeated exposure to trauma, adverse childhood experiences, lack of investment in communities, and lack of economic opportunities. We've already discussed the higher incidence of firearm injury among rural white males and urban black males. Other groups at higher risk for firearm injury include patients with young children in the home, elderly patients, and patients with dementia. UC Davis Health's What You Can Do program has compiled a list of additional individual risk factors that are associated with firearm violence. This list includes suicidal or homicidal ideation, abuse of alcohol and controlled substances, acute injury, history of violent behavior, for example, a suicide attempt, history of violent victimization, poorly controlled severe mental illness, abusive partner, serious life stressors, and impaired cognition or judgment. When working with patients who are subject to any of these individual risk factors or demographics, it is important to consider starting a conversation to ask about access to guns. We learned in the previous model that suicides comprise the majority of the firearm-related mortalities in the U.S. So let's take a closer look at the relationship between guns and patients with suicidal ideation. Firearms are not the most common method of attempted suicide, but 85% of suicide attempts with a firearm end in death. Compared to drug overdose, which is the most common method of attempted suicide, this is a very high fatality rate. Suicidal drug overdose results in fatalities less than 3% of the time, whereas many drug overdoses can be reversed or treated acutely. Firearm injuries are often devastating and irreversible the instant they occur. Suicides are often impulsive, and the choice of method depends on what is available. Rates of firearm suicides in states with the highest rate of gun ownership are 3.7 times higher for men and 7.9 times higher for women. Removing the means of suicide does not simply make patients with suicidal ideation seek other means. In fact, there is data to show that removing the means reduces the overall rate of suicide. If we start a discussion about firearms access with patients who have active suicidal ideation, it is possible to make a significant difference in reducing the number of suicides by firearm. Now that we've identified who to ask, let's discuss how to ask. In order to have a successful conversation with your patients, your context and attitude are absolutely critical. Place the conversation within the context of local cultural norms. This will vary by state, county, even community, so it is important to be aware and in tune with your patient population. Conversations should be individualized. Tailor topics to your patient's unique needs and circumstances. And lastly, conversations about gun safety should ideally occur within well-established clinician-patient relationships and focus on well-being and safety. Patients are most open to counseling when the conversation follows these guidelines. What exactly should we ask? The best way to avoid confusion or ambiguity is to ask directly. It is important to ask one question at a time, waiting for the patient to fully finish his or her response before asking the next one. Standard questions include, do you have access to firearms? If so, where are they stored? How are they stored? Who has access to these firearms? Discuss the risk factors that we have covered earlier in this module. Are there any high-risk individuals in the patient's home? Ask about the 5 L's. Is the gun locked? Is it loaded? Are there little children in the home? Is the operator feeling low? And is the owner learned and well-versed in firearm safety? Your patient has just disclosed a lot of useful information. If firearms are present, you have learned if they are properly stored, if there are high-risk individuals who may have access to the firearm, if the operator is trained to use a gun safely. Even if firearms are not present, broaching this conversation can help set up an environment where you and your patient can have open, honest discussions about safety and well-being in the home. After your discussion, you may have enough information to determine a level of risk for your patient and decide if intervention is warranted. These interventions can range from education or counseling in support of behavior change to disclosure to others to prevent death or serious injury. There is not really such a thing as a low-risk patient if there is a firearm stored in the home. So here we define risk on a spectrum of standard to high. Standard risk would refer to patients who have a firearm safely stored in the home, do not have children in the home, and have no other risk factors of those discussed, such as alcohol abuse or mental health issues. Patients at medium risk would include those who have unlocked or improperly stored firearms in the home, if multiple adult members of the home have access to the firearm, or if there are some history of alcohol or drug abuse. High-risk groups include suicidal or high risk of self-injury patients, alcoholics, patients with young children in the home, elderly patients, patients with dementia, and patients who may have been involved in intimate partner violence. Statistically, women in these relationships are at higher risk than men. Beginning with standard risk patients, or those without any additional risk factors, healthcare providers should educate as needed on safe gun storage. Discuss with your patients that firearms should be stored locked, unloaded, and ammunition should be stored separately away from the firearms and also locked. Methods for safe storage of a gun include gun cases or safes, lock boxes, gun cabinets, or trigger or cable locks. These options range from cheap to more expensive, with trigger locks costing under $10 and certain gun safes and cabinets with fingerprint biometric modules costing between $300 and $500. Safe storage has been shown to decrease the risk of suicide and unintentional injury. Also advise standard risk patients to reassess the use of their firearms and their storage in the home. If properly stored, privately owned guns do not legally need to be stored in the house. For example, a shotgun used for protection from intruders might be stored in the home where it can be quickly accessed in case of an emergency, whereas recreational hunting rifles can be stored outside the home. Examples of alternative remote locations include any secure warehouse, storage unit, a garage, a remote building such as a hunting lodge. Remember that in these remote locations the gun must still be stored properly, locked and unloaded. But removing unnecessary firearms from the home, reduces risk of accidental injury and unintended access. A vehicle is not a safe place to keep a gun. Children can easily access guns left in cars, and cars are often targets for gun theft. As we continue along the spectrum towards increased risk, it is important to continue checking in with patients during subsequent appointments, asking where they store their guns and how, and if they live with others who know where they store their guns. Mental health screening for patients is also particularly important at this stage. If providers take note of a changing mental health status for their longitudinal patients, this could indicate an increasing risk of firearm injury or violence for patients who are gun owners. For groups at high risk for firearm violence, the healthcare provider will need to continue to discuss safe storage of guns, as presented earlier, and take appropriate action based on the risk factor or factors present. For parents with children in the home, it is critically important to address safe gun storage to avoid accidental shootings, commonly referred to as family fire. The American College of Surgeons Committee on Trauma reports that 2/3 of accidental child gun deaths could have been prevented if guns had been stored locked and unloaded. Parents and caregivers should also ask about gun safety and storage when their children are visiting other homes that may have guns. Patients interested in safe disposal of unwanted guns can call the local non-emergency police line to ask about the following. Surrender programs. Through a surrender program, some states will allow people to bring a gun to the police without being charged if the gun is unlicensed or found to have been used in a crime. Gun buyback programs. Some programs give cash, gift cards, or other vouchers in exchange for turning over a firearm to the local police. Donation to training programs. Some agencies will accept gun donations to be used for police training. Deactivation. A gunsmith can convert a gun to make it unable to shoot. And sale to dealers. Guns can be sold to licensed dealers who have the ability to perform a background check. Some high-risk patients may come to you in acute emergency situations that require immediate action. For a patient with acute suicidal ideation, you may need to consider a mandatory inpatient stay. Such a stay may diffuse imminent risk and allow more time for intensive counseling. For patients with suicidal or homicidal ideation or who may be involved in intimate partner violence, you may wish to advise safe removal of the firearm from the home. Voluntary firearm removal can be accomplished by surrendering a firearm to the local police department. If your patient is in imminent danger of gun violence or causing gun violence against others, as their physician, you have an obligation to share relevant information with relevant persons, such as family members or law enforcement, in order to mitigate imminent risk to the patient or others. Although HIPAA privacy laws are in place to safeguard medical information, there are circumstances involving acute high risk to patients and others that allow for exceptions to be made to HIPAA without violating privacy rights. As the physician for a patient in acute high risk, you may have the authority under HIPAA exceptions to disclose otherwise protected information to authorities or friends and families of the patient, so long as it is in the best interest of the patient, or necessary to prevent or lessen a serious and imminent threat to the health and safety of a person or the public. You may want to review both the HIPAA Privacy and Emergency Situations Bulletin and HIPAA Privacy Rule and Sharing Information Related to Mental Health document published by the U.S. Department of Health and Human Services. Thank you for your interest in addressing firearm safety. This course has provided concrete actions that you can take to make your patients and their loved ones safer. We've identified some bonus steps that you can take to increase your impact on reducing rates of firearm injury. First, continue to refine your understanding of the epidemiology of firearm risk. Keep up to date on knowledge regarding what populations are at risk for which injuries and what factors play a role in the patient's desire or need to have a firearm. Learn about the community and the cultural factors at play in the place of your practice, and consider the socioeconomic and environmental factors that impact individual risks of your patients. Next, identify your role as a potential advocate both at the bedside and politically. Get informed about community-based clinical and legislative advocacy strategies. Become familiar with local and national programming available to your patients. Find ways to contribute to narrowing the current gap in firearm injury prevention research, such as developing screening tools or finding a local advocacy group. Third, understand the laws in your state. Learn about gag laws and how they have been deemed unconstitutional. Fourth, practice your interview skills. Exposure to patient interview scenarios across different specialties will strengthen your abilities to make you more comfortable discussing firearms with your patients. Understand which patients are at risk for injury and when having the firearms safety conversation is necessary. Learn how to have firearms conversations in a respectful, collaborative, and non-threatening manner. Finally, take initiative. We recognize firearm injury prevention education is lacking in most medical schools at this time. You've completed this basic training today, but we encourage you to use materials provided in our resources section to continue educating yourself and the students around you. In this module, we have become familiar with the current American Medical Association policy, which is that the American Medical Association recognizes firearms as a serious public health problem and supports communicating with patients. We've learned the role physicians can play in discussing firearms with our patients. Risk stratification is key when talking to our patients, keeping risk factors in mind during the interview. Remember the 5 L's when discussing with your patients. Is the gun locked? Is it loaded? Are there little children in the home? Is the operator feeling low? And has the owner learned and well-versed in firearm safety? And finally, we've identified the different categories: standard, increasing, and high risk for patients, and the different approaches used in each setting. High risk factors include suicidal or homicidal ideation, alcohol or drug abuse, and having children in the home. But all patients should be asked about firearm access. Thank you for your time.